lower morbidity for the patient, shorter hospitalizations, better bone stock preservation, and a lower economic burden for the system. But some of the cons are earlier studies have shown quite poor results with DAIR. Prior studies have shown there's penalties for DAIR treatment. I'll show you one of them coming up. And then salvage is unlikely past 28 days. You need to catch these and treat these early. And so this is one of the earlier studies out of CORE 2011 that looked at as failed DAIR, and then patients who underwent a two-stage revision after that, they had a 68% failure rate. So even though you may be thinking we're doing the less invasive thing for our patients, if you do it and it fails, and then you have to do a two-stage anyway, they ultimately have poorer outcomes. And so again, looking at these early papers showing lower success rate, this was an early article that looked at a systematic review of 15 articles over the course of many years. They had almost 800 patients. For a single IND, they only had a 44% success rate, and if you had a repeat IND, it only went up to 52, so not much more. But as far as when I started looking at some of these early papers, it seems that some of them didn't all do poly exchanges from my understanding of reading them. One in particular out of Rothman and Jefferson looked at 106 patients, and if you just look at their knees, only 26 of their knees had an actual poly exchange, and the other 27, they say that the poly was removed, soaked in betadine, washed, and then reimplanted. And again, I don't think that this is necessarily the way that we would do a DAIR today, but they only had a 44% success rate. So I'm curious if I went into all those different articles, if that would have been what they did in those as well. So let's get to our case. We have a 65-year-old male. He's a diabetic, obese, hypertension, hyperlipidemia, and coronary artery disease with stents. He had prior history of knee replacements done in an outside institution, and then he had a ground level fall at home, and he was transferred to our hospital from an outside institution. He had multiple surgeries, which we're going to get into. And so this is what he had back in 2017. He had a spiral distal femur fracture. It's non-comminuted. It doesn't appear to affect the knee replacement. In the emergency room, he was placed in a splint. A CT scan was performed to again confirm that the fracture did not extend into the knee replacement. There's no comminution. And so by the same orthopedic trauma surgeon that Dr. Ippolito showed us, he took him to the operating room for a very nice open reduction internal fixation. And so almost 3 months follow-up, he started having some increased left knee pain and swelling right over the distal aspect of the incision. He had a 1.5 raised area with drainage. A knee aspiration was performed at that time in the office. As you can see here, really not concerning for infection at this point in time, culture negative, alpha defensive negative, and he was empirically started on antibiotics for a stitch abscess. And here's the x-rays at that point in time. You can still see that the fracture is well aligned, but you can still see the fracture line, so it's not completely healed at this point in time. 2 weeks later, the patient comes back, worsening knee pain and swelling. He was concerned for worsening of infection. He was planned to go to the right from the office to the hospital. This is kind of where I got involved. You can see his ESR and CRP are extremely elevated. We performed a Doppler for DVT. Again, this is 12/19. The surgery was the next day. So when I saw him the following morning, we aspirated his knee, and you can see now he's got 38,000 white cells with 89% neutrophils. Of course, his cultures are pending. Trauma had worked him up to see if he had gone on to union, and you can still see the fracture not completely healed at this point in time. And so the plan from a trauma perspective was going to go to removal of hardware, the femur, IND, and a gray nail, and absorbable beads, and I was involved. I was going to perform a DAIR with a poly exchange of the left knee, as at this point in time our diagnosis was acute periprosthetic joint infection, because it only happened less than 2 weeks ago. And so this is what was done, exchange nailing and IND poly exchange. And so just to go a little bit of the procedure to how I performed it. So trauma had done what they were doing with the nail, and after they were done, I used betadine prep and new drapes over the prior existing drapes. We used 3 liters of antibiotic irrigation, and typically I do not use antibiotic irrigation. I think it might have just been drawn up for me at the time, but we know that that hasn't really been shown to be any better. At that point in time, we'll change our outer gloves, we'll do a second look debridement, then I did some more saline, betadine soak, more saline, hydrogen peroxide soak, and more saline, so a total of 9 liters of saline. And this is earlier on in my practice, and so now I've added, in addition to the betadine and the hydrogen peroxide, I also use back to shore in between the liters of saline. There we go. And then so we placed a new down sheet, everybody changed their gloves, and then a new poly was placed over a deep drain with a non-braided suture for the closure. And if I'm looking back again, this was a year into practice for me. I 100% of the time do a clean and dirty setup for all of my infected cases. Obviously, reading my op report, they did not do it at this time. And anybody who performs a clean and dirty setup, there's a lot of things that are necessary. So this is just an example of my Excel spreadsheet that I print up and bring with me to the OR. Because you may be doing these not with your usual team, so it's very easy to give somebody an Excel spreadsheet. Hey, pull all this stuff for me on the clean and dirty part. And so I just put that there for example. Well, unfortunately, those cultures that we took the morning of surgery ended up growing MRSA, which is unfortunate because it has a very high failure rate, and I'll show you that later on. So the patient was improving following surgery. Intraoperative culture is positive for MRSA as well. IV console was placed, 6 weeks of IV Dapto, followed by chronic PO suppression with doxycycline was his plan, and less than 3 months later, while he was still on the oral doxycycline, he had increased knee pain and swelling. Elevated inflammatory markers, infection is back, growing MRSA again, so now he's got a chronic PJI. So just a show of hands at this point in time, anybody would do a repeat DAIR on this gentleman? No? 1 stage? 1.5 stage? 2 stage? So we planned for a 1.5 stage at this point in time. Though I don't know if I was calling it that because this is very early and not many people were calling it that early. But we used an articulating spacer, so what I used for my 1.5 stages is a metal femur and an all poly tibia. We did high dose antibiotic bone cement. This is earlier on, per bag of cement I used 3 grams of Vanco and 0.5 of Gen. Now it's generally 3 of Vanco and 3.8 of Tobra per bag. And then the trauma surgeons did an exchange antibiotic rod with a reinterrogated aspirator technique to debride out the inside of the femur. And so this is what we did. If I'm being hypercritical, certainly it looks like my tibia is in a touch of varus, the knee's in some hyperextension. For anybody who's done these, sometimes it's not very easy to get the tibia on before you put the femur in. So you kind of do a trial reduction before you cement everything in, and a lot of times you have to put the femur on and then use a Homan to like flex it up over the tibia to get it in there. So it's difficult to get all of that cement behind the poly out at some point in time. But nonetheless, this is what we did. Again, IV Dapto, 6 weeks, chronic PO suppression with Bactrim. He didn't want any further surgery at this point in time. And this is the x-rays of the femur. And so now we're 10 months later, he does have some continued knee instability that's bothering him, and he's interested in a 2nd stage. And so, knowing he could still be chronically infected, we gave him an over 3-week antibiotic holiday. His ESR is slightly elevated, CRP is back to normal. I performed an aspiration in the office, culture negative, and no white blood cells. So we planned him at 1 year because we needed his fracture to be healed as well. So again, the trauma surgeons removed the nail, and then I did a revision knee replacement. I did not resurface my patella, as it was just a shell of bone. 7 months post-op, his knee range of motion is 0 to 100 degrees. He did have some chronic lateral pain, but overall is much improved from before the surgery. He hasn't followed up with me in 6 years, so he must be doing great. But I do have access to the medical records, and he's still alive, and from what I can see, he has no further surgery, no infections in his knee. And so let's go back to some of the research. So some of the earlier papers have really showed poor results with DAIR, but I think in recent years in the literature, there seems to have been a resurgence in this procedure with better results for selective indications with the DAIR. And again, going back, we want a healthy host. We want to get to this early. Implants need to be well fixed, and as we went through before. And so obviously MRSA, this study out of multi-center retrospective study, had shown pretty much like an 84% failure rate with MRSA. So certainly I think if I could have gone back and known it was MRSA at the time, maybe I would have planned a 1.5 stage right off the bat, knowing it has a very low success rate. But again, we also want to get to it quicker than not, but we didn't have that available at the time. So it was probably destined to fail from the get-go. What about a 2-stage versus a 2-stage after DAIR? And prior literature had been shown pretty poor outcomes, but in this paper, at the Journal of Arthroplasty 2019, the DAIR success rate was 67%. And when they looked at their failed DAIR patients that then underwent a 2-stage versus patients that underwent a 2-stage right off the bat, at At 6 years, there was no statistical significance in the percentage of success rate. The International Consensus Meeting had met in Philadelphia back in 2018, published these studies, and basically symptoms less than 4 weeks with a stable implant, recommendation for DAIR, and surgery should be performed within 7 days and don't want to wait until an organism is identified. And furthermore, they explain things like adding rifampin to an antibiotic regimen when combined with fluoroquinolone. As you can see here, certainly this is going to be something that's discussed with your infectious disease colleagues. More papers discussing early debridement within 3 days, no more than 3 weeks after symptoms, and another paper showing you want well-fixed implants, viable antibiotic therapies, and a healthy host in order to have success with a DAIR. Another study out of the Mayo Clinic showed great type grade A hosts having much better outcomes and success with DAIR versus type C hosts. Our patient certainly wasn't a type A host, being obese and diabetic. And then as far as time to DAIR, so this was a retrospective cohort study that looked at time to DAIR after total knee. They had 58 patients. Their median time to DAIR was 21 days with an overall success rate pretty good at 84%. And interesting dichotomy, if those successful patients that are treated within 90 days of their knee replacement had a 90% success rate, but if you had patients treated after 90 days of their initial primary knee, that dropped to 60%. So we've talked a lot about antibiotics, and this is a very interesting thing, and oftentimes a discussion I have with Dr. Deaver as far as extended antibiotics after the case, and a lot of times it's saying, well, we might be treating ourselves more than we're treating our patients, but this was a very interesting study that I found. So looking at extended course of oral antibiotics had independently predicted treatment success for treatment in DAIR and periparasitic joint infections. There's no significant difference in adverse events with IV alone versus the extended oral. They showed no difference after 1 year. So keeping on lifelong suppression, again, we may be treating ourselves more than we're treating our patients. And they did find that culture-negative PJI or Staph aureus did have higher failure rates, but still better outcomes in the extended antibiotic group versus IV alone. And then another study that for DAIR looked at systematic review of the literature showed 970 patients over 12 studies with a mean success rate of 71%, with their conclusions being that DAIR is successful in the early post-op acute hematogenous PJI. And double DAIR has been something that's been discussed and has been done at a Mayo Clinic in Arizona. And this is, as I was preparing for this is not even published yet, but it's pre-proof. And so they looked at their retrospective data from when they initially published it, 128 patients, just to look at what they do in their double DAIR procedure. In the first stage, they're going to remove the poly, soak it in antibiotic solution. They use a sterile toothbrush, betadine chlorhexidine soap to scrub up the knee and debride everything. High-dose antibiotic beads. An average of 5 days later, they're going to come back. They're going to open everything up. They're going to remove the antibiotic beads, take out that old poly, and then put in a brand new poly. And for primary joint replacements, when they do this, their success rate is 86.1%, versus revision knee replacements when they do this, 71.4%. Independent risk factors of failure that they found were revision arthroplasty, acute hematogenous infections over acute post-op, and then a positive culture at the second debridement also portended poor outcomes. And so in conclusion, DAIR is a viable option for early post-operative or acute hematogenous infections. You should perform them urgently. A healthy host with well-fixed implants is the ideal candidate. Certainly further randomized controlled trials are necessary to compare DAIR to 1.52 stages for early PJI. Thank you very much, and this is my happy place that I go to at the end of the day in my basement.